Hey guys, it's the Generalist 105 CCFP Topics Podcast. Oh my god. Oh my goodness. Oh my atheist. Dr. Kristen Dawson is here. Do you remember Chris? Of course you do. This script is up her alley. She's a respirology fellow at Queen's. She's in Kingston. Just crushing it.
Wait, what are we talking about today, Caleb?
Pneumonia.
Pneumonia. Or is it...
Pneumonia.
Yeah, like our AFib. Pirates. Pneumonia.
Oh, we're off to a beautiful start. This scotch is really helping.
I know.
Today we're talking pneumonia. It's an exciting topic. Maybe not as exciting for me as it is for Dawson, but apparently, according to Mr. William Osler, considered the father of modern medicine, who trained at McGill, pneumonia is known as the old man's friend. He wrote that pneumonia may well be called the friend of the age, taken off it by in an acute, not often painful illness. The old man escapes these cold gradations of decay, so distressing to himself and his friends. End quote. Interestingly, Mr. Osler, Dr. Osler himself, died from complications of pneumonia.
We could go on about the history, but I'm just going to have a couple more tidbits because I think it's very interesting and it goes to show how long pneumonia has been with us in humanity. So, symptoms of pneumonia were first described by Hippocrates around 460 BC, but it wasn't until the 19th century that doctors were aware that pneumonia was its own condition and not a symptom of another disease.
Just the humors.
Just the humor.
Interesting tidbits of pneumonia related history. Dr. Edwin Klebs was the first person to observe bacteria causing this pneumonia under the microscope in 1875. And the bacterial genus Klebsiella was named after him.
And strep pneumo, the commonest cause of community-acquired pneumonia, was the first bacteria to be gram-stained to distinguish gram-positive from gram-negative bacteria. And this was done by Hans Christian Gram in 1884, so that's why it's called the Gram stain.
Oh my god, old white guys, hey? The Spanish flu in 1918, which was an H1N1 influenza A pandemic, killed more people than the First World War. It resulted in about 20 to 50 million deaths and was the second most deadly pandemic on record. In comparison, COVID-19, you guys might remember that one. The deaths stand at around 7 million according to the WHO in November 2023. But those people were mostly killed by ventilators.
Oh yeah, definitely. All right, so I think that's all the tidbits we need to go through now because Caleb, we have to talk about the CCFP objectives for pneumonia.
Huzzah! Objective 1. In a patient who presents without the classic respiratory signs and symptoms, include pneumonia in the differential.
When somebody comes in with delirium, we always have a chest x-ray ready to go because we know that sometimes people don't present classically. Also, you can get, I don't know if it's referred pain, but if you have a lower lobe pneumonia, it can actually present more like upper quadrant abdominal pain. But people can also present with things like chest pain, which is more pleuritic in nature. And then as with elderly people, they just kind of feel off. So you got to keep pneumonia on your differential, even if somebody does not have a cough or shortness of breath.
Objective 2. In a patient with signs and symptoms of pneumonia, do not rule out the diagnosis on the basis of a normal chest x-ray film. This is not a risk with pediatrics.
No.
They're positive until proven negative.
So I was actually very interested in this because they said consider dehydration as a cause of not having a typical chest x-ray finding of pneumonia, even though you have pneumonia. So I went to the literature and the only thing I could find was, interestingly, published in the Journal of Family Medicine. So I wonder if that's why they mentioned this in 2000. That radiographic expression of community-acquired pneumonia is affected by the volume status of the patient. However, there are very few data to support or refute this concept. But the study looked at radiographical progression of pneumonia on chest x-ray after admission to hospital and was found to be worsened in patients that had a higher BUN and higher fluid volume administered in the first 48 hours. So it wasn't actually answering the question, I don't think. Anyway, the College of Family Physicians wants you to be aware that if a patient is dehydrated, then they might not have a typical chest x-ray presentation for pneumonia.
Okay. If they haven't been in the ER where we give them 8 liters.
Yeah. And then they go into florid heart failure.
We are sorry, but this is our way. The one other part that was mentioned was neutropenic patients because they can present with a bit of a fever but no other symptoms. It says, as a respirologist, I am not this, so I'm told that respirologists are frequently consulted for febrile neutropenic patients. And if there's any doubt if the patient has a pneumonia or you think they might and their chest x-ray is negative, they should often get a CT chest as they might present more atypically and they can have some non-bacterial causes of pneumonia, which our radiology colleagues are much better at picking out for us. Think of things like fungal or chemotherapy-related pneumonitis. And some studies have shown a wide range, anywhere from 10 to 30% of pneumonias not seen on the chest x-ray are then appreciated on the CT.
Yeah, definitely. I mean, chest x-ray is a good screening exam, but if your pretest probability is high, I would just go for the CT chest if you can. The last population they wanted to talk about were people with HIV, and they may also present atypically, especially if they're immunocompromised. They might not mount that robust immune system response, which is usually what causes the infiltrates that we're seeing on chest x-ray. So again, if you have any concerns, really the CT chest is going to be your way to go. And it can also, as a respirologist, the pattern you see on CT can also help you in these patients. For example, in HIV, we think about things like pneumocystis. And if we look at the CT chest, that can guide us for better treatment for these patients.
I don't know if you guys can hear it, but she's desperately holding back from describing some of these classic non-lobar patterns.
I almost did too.
Well, I'm sitting back going, no, but we will not integrate this into our lives. This is why we need you. Objective 3. In a patient with a diagnosis of pneumonia, assess the risks for unusual pathogens.
This one was fun because they list some things that you're pimped on, but I have never seen yet.
Oh, wow.
Not all pneumonia is community-acquired lobar pneumonia. So you have to think about other types of pneumonia that it can be. So you always want to ask about aspiration risk factors, TB exposures, travel exposures, and then really unusual causes like chlamydia, psittacosis that you get apparently from certain types of birds. It's good to ask whether the patient has pets like parrots or cockatiels, and then also poultry like ducks and turkeys. Although this is very rare. Apparently there's only been 10 to 20 cases per year in the US of psittacosis. So if you're, lucky enough to diagnose that, then good for you.
I always want to impress the respirologist or the internal med doc. So if you've helped me do that, I'll say next, they have no parrots. They don't farm turkeys.
Then I know what you're talking about.
HIV, of course, can also predispose people to these weird and wonderful infections. So think about this if people have severe or recurrent pneumonia without any obvious underlying cause.
And in respirology, we routinely send off HIV serology for people that present with pretty gnarly pneumonias, even though they report being healthy. So this is something we routinely check. Another thing to ask about are recent travel, and then think about exposure to things like air conditioning towers, for example, in hotels or cruise ships. These can harbor bacteria, specifically Legionnaire's disease. So that's another interesting piece of history, but I will defer that for now. I also ask if people have traveled, if other people in their traveling party are sick as well, because that might tip you off. And then important to know where this person might have picked up if it is a bacterial pneumonia, because the resistance patterns to antibiotics can be very different depending on what countries people have traveled to.
Lastly, when we're thinking about aspiration, we should ask about risk factors, things like significant alcohol intake, because if they're found down, it's easy to vomit and suck in your own gastric contents. Seizure disorders for similar reasons, severe GERD, vomiting, and significant dysphagia. So if they post-stroke or they just have trouble swallowing or other causes of altered level of consciousness. I pronounce it dysphagia.
I know, it's like
It's on purpose and with philosophical
reasoning as to why.
Yeah. Objective 4. In patients with pre-existing medical problems and a new diagnosis of pneumonia, treat both the problems concurrently. Adjust the treatment plan for the pneumonia, taking into account concomitant medical problems. And that's it.
I guess what they're getting at here is, of course, if somebody has pneumonia, you want to treat the underlying infection, but you want to keep the whole person in mind and what other medical conditions they might have. So, for example, in the era of COVID, it's pretty standard now that patients automatically get dexamethasone for 10 days. And then if they have underlying asthma, should they go up in their asthma action plan while they concurrently have a pneumonia? And if they're in heart failure, then you should listen to our episode on heart failure.
That's a good point as well in terms of choosing the antibiotic. Less and less patients are on warfarin, so that's wonderful, but it's safe to assume there could be potential interactions if they are. Also consider the antibiotic itself and the specific side effects. Fluoroquinolones that everyone loves to hate, increased risk of delirium or Achilles tendon ruptures are considered, or macrolides and their potential QT prolongation, as well as nausea vomiting. And then with clindamycin, we always think about higher C. diff infection risk.
Nasty.
Objective 5. Identify patients through history taking, physical exam, and testing who are at high risk for complicated pneumonia and who would benefit from hospitalization even though clinically they might look okay.
So there's 2 prediction scores that are available that you can use, and I use this on MedCalc, but the 2 ones are KERB 65, which is pretty straightforward and I would say easier to remember, but the American Thoracic Society guidelines actually recommend using something called the PSI or PORT score. This score is a little more intensive, so some of the data you might not have available.
Yeah, and I'm a simple caveman emerge doc. I can only remember my one score that I've remembered forever. KERB 65 stands for C, confusion, U, urea greater than 7 millimoles, respiratory rate over 30, blood pressure less than 90 systolic or diastolic under 60, and the 65 is for patients who are 65 and older. You give a point for each one of those, add them up, and you'll predict their 30-day mortality or at least close to. 0 to 1, you can often consider treating them outpatient, give them some PO antibiotics, and give them good reasons to come back. A score of 2, you could consider outpatient with close follow-up versus inpatient, and then if they're 3 or more, probably you're talking about bringing them into the hospital and making sure they're doing okay over the next few days. Score of 6, which is all yeses, is a 28% 30-day mortality. We do not like that.
That's high. The PSI or PORT score is known as the Pneumonia Severity Index, and it actually includes 20 parameters. So I'm not going to go through them individually, but the maximum score that you can get is 350. So you can realize it's not intuitive, and they add different points for different criteria. But it also predicts mortality and will suggest whether you should treat them as an in versus outpatient. The problem is it requires quite a bit of blood work. So in an outpatient family medicine clinic, it might not be as practical.
Objective 6. In the patient with pneumonia and early signs of respiratory distress, assess them and reassess them periodically, assessing for the need for respiratory support, such as BiPAP, CPAP, intubation.
This was an interesting objective. I hope a lot of you aren't being forced to start non-invasive positive pressure ventilation in your offices, but we can certainly talk about it. So if patients are that sick, then I think they should be going to hospital. There is some controversy in the field in terms of people that have pneumonia, whether they should receive continuous high flow oxygen through a nasal cannula versus receive continuous positive airway pressure or bilevel, like i.e. CPAP or BiPAP. And the studies are mostly in determining the rates of intubation after receiving either type of oxygen delivery. So the study that people refer to is published in the New England Journal of Medicine in 2015. It was called the Florali study. You can look at that if you want more details, but basically if a patient needs supplemental oxygen, they should go to the Emerge and likely receive high flow nasal cannula for oxygen support.
Objective 7. For a patient with a confirmed diagnosis of pneumonia, make rational antibiotic choices.
This is actually kind of a big objective, and I'm sure infectious disease gets tons of consults with this. But basically the principles are that you want to choose antibiotics that will sufficiently cover the causative bacteria and also providing the narrowest coverage, because we don't want to drive resistant patterns in our bacteria. So it's always a good idea to know what you are treating. The most common causes of community-acquired pneumonia are strep pneumo by far, but other causes include Haemophilus influenzae, Staph aureus, Legionella, and Mycoplasma pneumoniae. So thankfully strep is overall pretty wimpy, and you don't need big guns in order to treat a patient.
According to the IDSA, the Infectious Disease Society of America, and the American Thoracic Society guidelines, healthy people without any other comorbid conditions or risk factors for the weird and wonderful, there are 3 options for treating them as an outpatient. What are those?
Those would be, number 1, amoxicillin, 1 gram TID. Your second choice is doxycycline, 100 milligrams BID. Or lastly, a macrolide, which we usually use as azithromycin, 500 milligrams on the first day, and then 250 milligrams for the remainder of the course, which is usually 5 days.
It's nice that matches up with Spectrum, I'm pretty sure, locally for Victoria, for sure. It must be fairly universal.
I think we're lucky in Canada. We don't have a ton of horribly multi-drug resistant bacteria.
The Amox is essentially treating the strep and the Haemophilus influenza, but the other 2 have atypical coverage for things like Mycoplasma. So if you're unsure, look at your local antibiogram or on the Spectrum app if you have local coverage for it, and to get an idea of your local resistance patterns to make sure you're covering the top bacteria in your community.
Yep. So those options we just went through were very healthy, robust people with no comorbid conditions. But if somebody has a comorbid condition, so example, diabetes, heart failure, renal disease, lung disease, liver disease, etc., then you need to step up your coverage a little bit. So there are 2 options here for outpatient management. The first option is a macrolide like azithro or doxycycline plus a cephalosporin or amoxiclav. And then your second choice is a solo respiratory fluoroquinolone.
Bacteria that you want to be weary for would be MRSA, of course, and Pseudomonas, as all the ones that we just talked about aren't going to cover those, and the patient might need hospitalization for IV Vanco or maybe Pip-Taz. The risk factors for this include prior antibiotics in the last 3 months, high crowd environments, so think of jails, shelters, if they've been recently hospitalized or in a healthcare environment, or known colonization. That's why we swab everyone that comes in the groin. Objective 8. In a patient receiving treatment for pneumonia that is not responsive, revise your diagnosis, consider atypical pathogens, and/or modify your therapy based on this.
Yep. So non-resolving pneumonia is a red flag, especially in respirology. So if the patient is not improving despite being on an antibiotic, you have to think, is it something I'm missing in terms of bacteria? Is it a wrong antibiotic, or is it just not an infection altogether? There are atypical infections that require slightly different types of treatment. PCP or PJP, which is used intermittently, but it's Pneumocystis jirovecii, is a fungal organism, and it causes pneumonia primarily in immunocompromised patients. So this should be on your differential for patients, especially nowadays. It used to primarily be HIV or patients with AIDS, but now that we have a lot of cancer therapies that are quite immunosuppressive, patients in that population are also starting to get these types of infections. Another one that should be on your differential is tuberculosis, especially because of public health implications. and the need to isolate if it's active TB. And then lastly, another thing that can happen is people can have post-obstructive pneumonia that's not getting better, and they might have an underlying mass or cancer that's driving the infection that makes it really difficult to treat.
Of course, you should know what the complications for untreated pneumonia are. This is things like necrotizing pneumonia, sounds bad. Empyema, this is a bunch of pus in the pleural space, and potentially pneumothorax secondary to these. These conditions might need a chest tube, they might need IV antibiotics, and so if this is happening, you should probably send them to the ED where we can get them to somebody to deal with that.
Yep, and never be afraid to refer to respirology. We see stuff like this frequently, and we would rather investigate it and get to the bottom of it rather than just keep trying antibiotics that aren't working for a patient.
Objective 9. Identify patients who would benefit from immunization or other treatments to reduce the incidence of pneumonia.
So now that I'm in the realm of respirology, we recommend vaccinations every single time for all of our patients, despite the reactions that we elicit in some people, which are interesting. But presently we have 4 vaccinations that we recommend that all of our patients get. So that would be a COVID-19 vaccination, which you can get every 6 months, seasonal influenza, typically in the fall, the pneumococcal vaccine, such as Pneumovax or Prevnar, and then now, excitingly, we have RSV. The only problem is it's not covered in Ontario. Bum, bum, bum.
The guidelines recommend that anyone over 6 months can get both COVID-19 and influenza vaccine, and these fine respirology folks are currently recommending repeat COVID-19 vaccine 6 months after the last one, or 6 months after you've had COVID-19, while influenza is yearly around fall time.
And then I tried to unpack the pneumococcal vaccine, but there's so many now, and I find it a little confusing. But basically there's 2 types. So there's the polysaccharide vaccine, which is called Pneumovax 23, and as the name implies, it covers 23 serotypes of strep pneumo. And the other one is the conjugate vaccine, and that's called Prevnar 20, and as the name implies, it covers 20 serotypes of strep pneumo. So the difference between these 2 is that the conjugate vaccine usually induces a stronger immune response, and it's likely to last longer and provide a more robust response when the person encounters the actual bacteria. The polysaccharide vaccine, on the other hand, tends to wane in its immune boosting ability after about 5 to 10 years. So the government of Canada is currently recommending that all people, regardless of health status above the age of 65, should receive 1 pneumococcal vaccine. So Pneumovax 23 is covered by the government, which is usually what people get, but at least in Ontario, unfortunately, the Prevnar 20 is not. That's the one that gives you kind of a stronger boost. So if patients want to pay for that out of pocket, it's about $150.
For that wonderful RSV vaccine, as of the writing of this script, it isn't covered by the government. It costs around $200 to $300, but respirology, of course, is recommending it for at-risk patients. That would be those with COPD, asthma, bronchiectasis, etc. Basically, if your lungs are not pristine, probably should get it.
Yeah. Other treatments for non-bacterial pneumonias. We can talk briefly about COVID-19. There is an option for Paxlovid. It's usually for outpatients to try to prevent hospitalization, and they have to have symptom onset within the past 5 days in order to receive it. There's also Tamiflu for patients that are diagnosed with influenza A or B and have had symptoms within the past 2 days. And then lastly, theoretically at least, there is a treatment for RSV in the form of ribavirin. Usually it's primarily used for hepatitis C treatment, and the only place I've ever seen this used was in Toronto because apparently it's very expensive. But it was used to treat a patient who had HIV and RSV, so he was given the ribavirin.
Cool. Objective 10. In patients with a diagnosis of pneumonia, ensure appropriate follow-up care.
Ideally, based on CURB 65 or the PORT score, depending on what you use, and you can get the patient to avoid hospitalization. You just want to make sure that the patient has good supports at home and very clear when to return to medical attention for reassessment. And interestingly, I found, at least in the era of COVID-19, some people have bought pulse oximeters that you just clip on your finger and have at home. So you can also encourage people to check their oxygen levels. And if they're becoming hypoxic or confused or their breathing's getting worse, then they should probably be reassessed and potentially admitted to hospital.
That was one nice outcome of COVID, is that there was like those take-home kits that you could mail back.
Yeah.
Super cool. There's some controversy on when and if you need repeat chest x-ray or CT chest. So we know imaging data can lag behind clinical resolution, of course. Apparently, they used to recommend repeat chest x-ray after improving from pneumonia to ensure there was no underlying malignancy that led to the pneumonia, which is interesting. 50% of patients should have radiographic resolution in about 2 weeks and 75% of patients within about 4 weeks. The risk factors for needing a longer time for radiographic resolution are people like smokers, being older, severe pneumonia.
So there is a push, I find, at least in our program, to refer to the Choosing Wisely Canada guidelines. So I was interested if they made any recommendations for repeat chest x-ray or CT after pneumonia. And they actually don't make a specific mention of this, but they do state that it shouldn't be used as a regular screening tool in otherwise healthy patients. So I would say use your clinical judgment and whether you need repeat imaging for somebody after they've had pneumonia.
And if the radiologist in the report says recommend follow-up chest x-ray to rule out underlying malignancy, then you should.
Or they could also, there is recommendations for smokers for low dose screening CTs for lung cancer. So if they fall in that population, then maybe just get a CT.
Objective 11. In patients with confirmed diagnosis of pneumonia, arrange contact tracing when it matters.
So it's always a good idea when you're diagnosing somebody with an infectious disease to double check whether it needs to be reported to public health or not. I've actually done this myself. You can search online depending on your province or territory and see a list of reportable communicable diseases. The list is actually very long. It does have all the things that you would expect. So any large institutional breakout of respiratory illnesses, tuberculosis, legionellosis, and then there's also weird and wonderful things that I, again, have not seen, but things like tularemia and Q fever, weird animal exposures.
I think it's so funny that I was tested on things like tularemia and Q fever, and I'll never see them. And you, who have never seen them, who is in respirology, is like, why would I ever be tested on such an... Anyway, medicine's stupid.
I agree.
But you are wonderful, and we're very happy to have you, and we're very lucky to have you. And it's late at night, and you've had a very busy week, but you did this for us and for all the wonderful budding family medicine physicians around the country. So thank you, 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 thank you.
It's a pleasure. I am happy to be here.
Thank you. You're the best.
Thank you.
Bye.
Bye.